My name is Jonathan Acevedo, as Karen mentioned. I'm a PhD candidate at the Lundquist Institute at Harbor-UCLA Medical Center. Dr. Polgreen, who just spoke moments ago, is my mentor, and today I will be discussing the therapeutic potential of cannabidiol and Sanfilippo syndrome. So next slide, please. So I'll start by introducing cannabidiol. So cannabidiol or CBD, is a non-psychoactive compound that's found in the cannabis plant, and this is something that can be administered orally. CBD has been shown to be safe and effective in the treatment of children with certain types of seizure disorders, and this has been a formulation of CBD has been approved by the FDA, and I will touch on that a little bit earlier. But additionally, on top of the effects that it has on seizures, it also has some potential therapeutic benefits, including pain management, sleep disturbances, and behavioral problems, to name a few. These are just some that are quite relevant to Sanfilippo syndrome, but there are others that have been reported as well. Next slide, please. So getting into CBD and its therapeutic mechanisms, I know this slide there's a lot going on, but the main thing that I want you guys to take away from the slide is just that the mechanisms that the potential therapeutic mechanisms that CBD has are very complex, and that CBD interacts with many different receptors and has different mechanisms by which it has these therapeutic effects. Just to name a few, I mean, as you can see in the top part of this graphic, it has anti-convulsant effects, anti-inflammatory effects, and antioxidant effects, which we believe would be relevant to Sanfilippo syndrome. And additionally, thanks to work that was done by a group in Italy, there has been work that has shown that in Sanfilippo syndrome, there is a dysregulation in the dopaminergic system and dopaminergic signaling. And there's been some work that has suggested that CBD has potential therapeutic role in the dopaminergic system. So for this reason, as well as the mechanisms that has been highlighted in this slide, we believe that it could be, there are many different targets that it could have therapeutic effects. So I want to highlight just one specific receptor or mechanism, and that's in one of the orange boxes, the GPR55. So for the next slide, I will be kind of zooming in on this specific mechanism. So next slide, please. So the GPR55 or G protein coupled receptor pathway is a pathway that is very important in many things in biology, but one of which that is relevant to us and the work that we are doing is that it's important in axonal formation and neuronal development. So some work that was done in Dr. Michelina Iacomino's lab, which Dr. Porter mentioned that she will be joining for the Q&A after to answer some questions. Some of the work that was done in her lab in certain proteomics testing was that we saw that there are many proteins that are dysregulated, especially upregulated in an MPS IIIB brain organoid model, where many of these proteins are involved in this G protein coupled receptor pathway. So this pathway is sort of primed to have a very large response, and a dysregulated pathway, especially when we're looking at neuronal development and axonal formation, can have many significant effects, especially as we will see here on the next slide, please. So as I mentioned, that G protein coupled receptor pathway is involved in neuronal development. So what we saw in a MPS IIIA forebrain neuron model, cell model, which these cells were actually patient-derived iPSCs that were later differentiated into neurons, cortical neurons. And what we see is that in the healthy control cells, they have this healthy morphology where they have a very small cell body, long, thin axons or dendrites, certain branching. And then in the MPS IIIA cells, we see this abnormal morphology where they have more of a short and wide shape to the neuron and a much larger cell body, which is demonstrated in the graphs down below, where the cell diameter, and this was just measuring the cell body, is significantly greater in the MPS IIIA neurons. And the percentage of these abnormal cells, which we just defined as those with the larger morphology, the large, short and wide morphology, was significantly greater. So we can see, and one thing that I want to clarify is the control cells still have this quote unquote abnormal morphology, but this is just representative of a certain stage in neuronal development. This is very normal for cells to start out this way in this shorter, wider shape. And then as they continue to develop and become mature neurons, they will elongate and appear more as the cells do on the left. So this is just the takeaway that I want to just highlight here is the fact that these cells, these were imaged at the exact same time point. However, the MPS IIIA cells appear more like the early developmental stage compared to the control cells. Next slide, please. And so we believe that this is related to the GPR55 pathway specifically. And on the little graphic on the left, we see that GPR55 is normally activated by LPI. This is just an endogenous or a molecule that occurs naturally in the body that activates this pathway. So in MPS III, we anticipate that LPI would bind to this receptor and cause a very large signaling response that basically will produce this abnormal morphology in the MPS IIIA neurons. However, CBD has been shown to be an antagonist of this pathway, and we believe that this will, we were looking at this pathway to see if it would correct that abnormal morphology in our MPS IIIA cells. And what we saw, first starting with the healthy control cells, the graph on the left, was at this early stage in development, we measured the percentage of abnormal cells in just healthy control cells, so they didn't receive any sort of treatment. And that baseline was at about 40% abnormal cells. However, when when the cells were exposed to LPI, which again is that molecule that activates this pathway, we see a significant increase in the percentage of abnormal cells. However, when cells were exposed to CBD, so that pathway is essentially like blocked or inhibited, then we see a significant reduction in the percent of abnormal cells and a number that is very similar to, or essentially the same number that we see in the control. However, we can see that at the 0.5 micromolar dose of CBD, there was just an uptick in the percentage of abnormal cells, and that's something that we're still trying to better understand. So there wasn't quite that dose response that we were hoping to see, but nonetheless, still was significantly lower than those cells that received LPI. And so most importantly, in the MPS IIIA cells, we see that at baseline, or the control cells, those that did not receive any sort of treatment, were at a much higher baseline in terms of what percentage of the cells were abnormal, at about 60%. And similarly, when those cells were exposed to LPI, we see the percentage of abnormal cells up to about 80%, which is similar to in the healthy controls. And then, just as we saw in the healthy control cells, we see that CBD significantly reduces the percentage of abnormal cells with a statistically significant reduction compared to controls in the 0.1 micromolar. And once again, we're seeing still a decrease in that percentage of abnormal cells in the higher dose. However, it's still a bit higher than the 0.1 dose. So that's something that we want to try to better understand, that we're actively testing in the lab. Next slide, please. So on top of just that specific mechanism, CBD has been shown to have anti-inflammatory effects. So in human studies, CBD has shown anti-inflammatory effects in humans by reducing the inflammatory cytokines, including VEGF, TNF-alpha, and IL-6. But more relevant to Sanfilippo syndrome, because this hasn't been tested in Sanfilippo, we also, again, Dr. Iacobino's lab, they measured the effects of CBD on MPS IIIB mice, and specifically in neuroinflammatory markers. So on the graph on the left, we see that CD68, which is a marker of microglia, sort of a neuronal, or sort of like a brain immune cell. We see that the MPS IIIB mice have significantly larger percentage of CD68 that are active in the brain compared to control mice. And then that's also the case with GFAP, which is just a marker of astrocytes, where we see a significantly larger amount of GFAP cells that are active in the MPS III mice compared to controls. And again, in the MPS III mice that received CBD, we saw a reduction in both CD68 and GFAP, so a decrease in the microglia and the astrocyte markers. and the astrocytes came down to almost the same level as controls. So that was just a kind of confirming our belief that CBD would be able to cross the blood-brain barrier and produce these anti-inflammatory effects in the brain as well as somatically. Next slide, please. So not only has CBD been shown to produce these therapeutic effects in like biological systems, but it's also been tested in a clinical setting. So in other populations, specifically because it hasn't yet been tested in Sanfilippo syndrome, we see that in autism spectrum disorder, there was a small study where 10 participants received a dose of 75 to 1, a ratio of 75 to 1 of CBD to THC. So it's CBD enriched cannabis over 6 months. And they showed that there were significant improvements in all of the symptoms that they measured, which is the graph on the right, which I will kind of walk through now. So starting with ADHD symptoms, they saw about a 30% improvement in the symptoms in this population. Behavioral disorders also saw about a 20% improvement in these symptoms. Same with motor deficits, they saw about a 20% improvement. The lowest amount of improvement that they saw was in autonomy deficits, but this was still about a 10% improvement compared to baseline. And then the communication and social interaction deficits saw about a 25-30% improvement. And then cognitive deficits also saw 20% improvement. But the largest improvements that were seen in this study specifically were in sleep disorders, where about 50% of the participants saw improvement in their, the participants saw about a 50% improvement in their symptoms. And this may be just related to the some of the side effects of CBD, where somnolence or like sleepiness is a common side effect that is seen in CBD. So that was not too much of a surprise, but definitely something that is very significant, especially in our population where sleep disorders are a big problem in Sanfilippo syndrome. Additionally, there was work that was investigating the effects of CBD in Fragile X syndrome. And this was, in this study, they were exposed to just CBD, no CBD to THC ratio here. And 3 months of CBD treatment improved all of the aberrant behavior subscales that they measured. Some of these include hyperactivity and irritability. These are just to name a few that are relevant to Sanfilippo syndrome. And lastly, Epidiolex, which is a pharmaceutical grade CBD, is currently FDA approved in pediatric populations for the treatment of seizures. And this is in specific populations such as Dravet syndrome and Lennox-Gastaut syndrome. Julie here will soon be talking about this. So I'm happy to, actually, sorry, I have one more slide before I pass it off to her. So this is why we are sort of turning towards Epidiolex or CBD for Sanfilippo syndrome. And part of the reason why we turned for this medication is because of the fact that during the anakinra trial, we noticed that about 30% of participants were currently taking CBD, whether it be over the counter or if they were prescribed Epidiolex for certain seizure conditions. That's still unknown, but basically, since we had a decently large proportion of the participants in the anakinra trial that are taking CBD, we want to make sure that we understand the dose that is required for if it has any sort of potential therapeutic effects, as well as just to test the safety of Epidiolex and Sanfilippo. And then additionally, just some of the therapeutic properties that are relevant to Sanfilippo that I highlighted in the presentation. That's because CBD has these properties, then we believe that it'll be a good candidate for a drug to test in Sanfilippo syndrome, as well as the fact that there's already proven safety and efficacy in other pediatric populations, however, in symptoms that are relevant to Sanfilippo. So for several of the reasons that have been highlighted, both in my talk and in Julie's talk, that's why we are turning towards Epidiolex and testing that on to see if Epidiolex has any sort of therapeutic effects on Sanfilippo syndrome. Specifically, we will be measuring the neurobehavioral and functional outcomes. This will be in a phase 1, 2, 3 clinical trial, where the first portion of the trial will be the sentinel safety cohort, where the first 5 participants will be screened, and then they will all be taking Epidiolex, and they will be titrating in a dose for the first 4 weeks. This will be done to test the tolerability, as well as sort of a preliminary efficacy dose that will then be used in the subsequent cohort. So after 4 weeks of Epidiolex, then they will have the option, participants will have the option to participate in the open label extension, where they will have the opportunity to receive that maximally tolerated dose for 52 weeks. So in this trial design, which we are hoping to sort of just do it on one go, this sentinel safety cohort will sort of act as the phase 1-2 portion of the trial, where we're testing safety and tolerability. And then next slide, please. This second cohort will be the phase 3, and this will be a placebo-controlled cohort where participants will be screened, and then if they pass screening, they will be randomized into one of two groups, where they will, I'll direct your attention to like the top line, for example, that will just be, we'll call it Group A. Group A will receive Epidiolex for 16 weeks at various doses. And at the same time, the other half of the participants that are randomized to placebo will receive placebo for 16 weeks. They will then have an 8-week washout period to ensure that CBD is completely out of their system, and then cross over to the opposite group. So Group A will then receive placebo for 16 weeks. Group B will receive Epidiolex for 16 weeks at various doses. And then again, to test long-term efficacy as well as safety and tolerability, we will give all participants an opportunity to participate in the open label extension, where they will all receive that maximum tolerated dose for an additional 52 weeks. And next slide, please. So I just wanted to highlight some of the key inclusion-exclusion criteria, because I'm sure people will have questions, and I want to provide some information, since we are hoping to get this trial going as soon as possible. Some of the exclusion or inclusion criteria will include, obviously, an MPS III diagnosis that is confirmed by genetic testing. We require that they are at least 4 years of age or greater, as well as if they are on either anakinra, fluoxetine, or any probiotic supplements, that there are no dose changes in the last 8 weeks on any of these medications. And then for some of the key exclusion criteria, no participant can take any form of cannabis, including CBD, especially if it's over the counter, in the last 8 weeks. So that's one of the things that I want to highlight specifically for this talk, because if any participant who's interested in participating in this trial, then there's some time to sort of wean off of the cannabis product that they might be on between now and when we hopefully start enrolling soon. As well as no recreational or medical use of THC within the last 3 months. And then some of the concomitant use of therapies, including rifampin, diazepam, except for intermittent uses as needed as a rescue medication, or clobazam, valproate, and there are a few others, but these were just some of the more common ones that I wanted to highlight. And next slide, please. So I just want to say thank you to everyone. Again, I wanted to thank your Sanfilippo Foundation